who she is or testimonial. When you need a surgeon, you want someone who's more than their credentials. And you want someone whose wisdom you can trust. You want someone who will listen. I really love her. Who will listen attentively with compassion, respond with her best advice, support you as a unique individual, and partner with you to develop a plan together that supports your healing path for a best possible outcome. That's how I know Dr. Colette. You can trust her intellect, her hand under the knife as a surgeon, and her guidance in your follow-up care. Thank you, Dr. Colette, for all the ways that you've helped so many people. It's my deepest pleasure to introduce Dr. Salm-Schmid.
Well, my last name is weird. My maiden name is Salm, and my married name is Schmid. And in medical school, in order to get my degree, I would have to pay extra money if I wanted to be Dr. Schmid, but I didn't have to pay any money if I hyphenated. And so that's how the hyphenated came in. But once I got out, I'm like, nobody can say my name, so I'm really Dr. Colette, and Dr. Colette is perfectly acceptable. They asked me to come today to talk about breast cancer and advances in prevention and innovations, really. And so here I am today, and I like a small group, so I was glad it wasn't the Phoenix room. I'm glad we're in a small group. I prefer that. Can everybody hear me? So I don't have to worry about the microphone.
Could I ask you to use the microphone?
Oh, yeah.
Because we're trying to record the...
You can. Is that better? All right, now, let's see if I can get it to advance. Maybe. You can hear it.
There it goes.
Well, there you go. So we're going to talk about what are the causes of breast cancer. Because we heard some on the last one. She did a great job. I thought that was remarkable. I'm not an environmental person. I'm not a researcher. I'm just like the basic person who holds a knife and cuts on people. So we're going to go with the baby version of this, okay? Baby version. We're going to talk about how we can prevent breast cancer and are there any advances in early detection. So that's what we're going to talk about. Now I hit a bunch of buttons, so I'm not sure which one worked. Okay, so what are the causes? We're going all the way back. We're going to start at, we're made of cells, okay? So she talked about those cells. And then when those cells group together, they form little structures that are DNA. And that's the instruction manual for the cell, okay? And then those cells organize and we form tissue. So we can form breast tissue. And when those cells get together in breast tissues, they form organs. And then when those organs get together, they form systems and then we create a body. All right, so we went all the way back, all right? But the big thing to remember is it's about that instruction manual. So when I listened to her talk, she said, yes, there are about 10% of cancers that are affected by hereditary genetic problems. But every cancer is caused by a problem with the instruction manual. So what she said is, she said environmental things can cause disruption in pathways. Those pathways are disruptions in the manual. And so every cancer is caused by a problem with the genetic structure. It may not be inherited though. So one of the things that's really interesting about our bodies is every day our body picks up mistakes from the day we're born. And every day our cells are turning over. And so some researchers think that most cancers are just caused by the fact that our cells are multiplying over and over and over and over and over again. It's amazing they do as good as they do, right? We have all these redundant pathways so that all these hits to the DNA are taken care of all day long from the day we're born. But every cancer is caused by those DNA hits. And those DNA mistakes, or whatever you want to call them, usually do two things which form a cancer. One, they create cells without a stop button. Normal cells multiply a certain number of times and they die. Cancers don't. They just multiply. They just multiply. They don't have a stop button. And the second thing is cancers can invade. What kills you in breast cancer isn't the breast cancer in the breast. It's a breast cancer that figures out how to go somewhere else. That's what kills you. So the ability to invade and then a cell without a stop button. Those are really the two big genetic hits that happen. How they happen, why they happen. We have researchers looking at that for so long, trying to figure out exactly why that happens. And we have some ideas. We have some ideas. Now one screen moved, but the other one didn't. So that's interesting. Let's try again. There. So the breast is, can I use the handheld? I can't stand still. Can I use just the regular? You know, this is going to kill me to be in one place. Can I just take it off? Oh, I love it. And then I can see my slides, so I make sure I know what I said. Thank you so much. All right, that's so much better. I'm free now. All right, so most importantly, what is the breast? The breast is an organ, so made up of tissues. It's made up of lobules arranged like spokes on a wheel. There are 12 to 15 lobules arranged like spokes on a wheel. Those lobules are like grapes on a vine. The grapes are the machinery that make the milk. They go down the vines, and then all the vines come out at the nipple, and that's how we make a breast. So most cancers are a cancer or a cell without a stop button in the ducts. There are a few other ones, but 80% of breast cancers, it's in the ducts, and then it figures out how to get out. So how does it do that? Well, those ducts are lined by a single layer of cells. Now, they can get more than one layer of cells. That happens to all of us. And those two go back and forth. That happens to guys too. You have breast tissue, you have ducts, you have lobules. They're just not fluffy. Your grapes are all skinny because you don't have the estrogen around to make them fluffy. And so, if you have a normal duct with a single layer of cells, great. If you have more than one layer of cells, that's okay too. Those two go back and forth. We all have a little bit of both. The problem comes if you make more than one layer of cells and now you make some mistakes. Now, we have systems in place. I just told you, from the day you're born all day long, our body picks up those funny looking cells and says, hey, I got to get rid of you. But if it doesn't, that's when we start to make a cancer. We make those funny looking cells and for some reason the body didn't pick them up. We don't know why they didn't pick them up. Diet, activity, stress, alcohol, environment, diabetes, we don't know. We wish we knew. If it was a single thing, if it was electrical lines, we would have figured it out by now. But it's not. It's more than one thing, and it's a combination of things in some way that we haven't quite figured out. And maybe the environment's going to be the key. We don't know. So what are the causes? All kinds of things. We heard about hormonal dysregulation from environmental causes, which is a nice way to put that the environment's causing our hormones to do things we don't want them to do. Proliferation, DNA repair, carcinogen, cell cycle, apoptosis. Apoptosis is the cell's normal cycle where it goes through and actually dies. If that's dysregulated in some way, and we have a cell without a stop button, that's a problem. And then inflammation and immunity. That's it. This whole COVID and inflammation is going to turn out to be possibly something we don't know. We think so, though. I mean, just the systemic inflammation from COVID may cause problems with cells. And we may see an increased risk of breast cancer, but we won't see it for a while. We heard the researcher, Dr. O'Hayan. We heard her say the latency, can be 10, 20 years before we're going to actually see that. So how can we prevent breast cancer? All right. Well, prevention of breast cancer isn't really like if we do this, we won't get it. I wish it was like that. It's more about managing your risk and managing your risk factors. And some risk factors we can't manage. I can't manage the fact that I was born female or male. So we know that a female is just 100 times more likely to get breast cancer because we have more breast tissue. And so it's interesting. Just being female, just getting older. I wish I could stop that, but I can't stop that. But just getting older, my body has had to fix cells and mistakes all day long for the day it's born. As we get older, we make more mistakes, we have more problems. And then there's a lot more modifiable risk factors that we can do something about. Risk factors in breast cancer include just being female, your age, family history, and I'm saving most of the genetic stuff for Sumeda because she's amazing and she'll give you so much information. We'll talk a little bit about it. Ethnicity, we know that whether you're white, we have a lot of data on you, but if you're African American, we have some data. If you're Native American, breast cancer affects them differently than if you're Asian. So we'll talk a little bit about that. There are breast-related factors. Just having a dense breast makes a difference. And breast density is something you're born with. You can't change that. We wish you could change it, but you can't change that. The number of breast biopsies, if you have a busy breast. If you actually have a biopsy that shows that you have those funny looking cells, atypical cells, that increases your risk and we can intervene. And then high risk lesions. There are other lesions that we take out that can be high risk, that can affect your risk. Oh, the hard ones, the lifestyle things are always hard. We know if you're overweight, it increases your risk of 7 cancers. Breast is just one of them. Our alcohol consumption increases your risk, and we'll talk more about that. A sedentary lifestyle. We got to move. It makes a difference in whether we get cancer or not. And then estrogen exposure. We're going to go through those. And then chest radiation before age 30. And there's probably a whole bunch more that we just heard about in our last talk about the environmental factors. So, males, you lucked out. You can get other cancers. Your equivalent to breast cancer is prostate cancer. That is your equivalent. You can get breast cancer. Females are 100 times more likely to get it. Males, it occurs in about 1%, but it is increasing, which is interesting. But there's a lot of, it's hard to say exactly what that's about. There's a lot of confounding factors. We're just getting heavier. Every fat cell makes a little bit more estrogen. If we get more estrogen, then males have more breast tissue. And then if they have more breast tissue, then they're more at increased risk. That's just one theory, right? So there's so many different theories to that one. It increases with age. So we talk all the time about 1 in 8 women can get breast cancer by the time they're 85. But if a woman comes in my office and she has a lump, it's most likely if she's under 30, not breast cancer. Can she be? It can be, and I have to do due diligence, but she has a 1 in 227 risk of breast cancer. Very different than 1 in 8. If you're between 40 and 50, it's 1 in 68. If you're between 50 and 60, it's 1 in 42. Now we're getting somewhere. All right, and then 60 and 70, it's 1 in 28, and 1 in 8 by 85. So as you get older, it increases your risk. If you're the one with breast cancer, though, like it's 100%, right? So these are just numbers. Median age is 62, but you can see how there's a distribution. There are women under 40 who are getting breast cancer, and unfortunately I get to see them. But it's not as common as the average person who comes to my office is over 60. And really, lately I think it's the 80-year-olds that I'm getting. But the baby boomers are now in that age group. And so there's so much breast cancer around just because there's so many baby boomers around. So family history of breast cancer, Sumeda's going to talk about this more. This is my baby version of genetics that I talk to my patients about, but it's the baby version. She's got the real version. All cancers are a result of a problem with the DNA getting hit. It causes the cell to either grow uncontrollably or invade. One of those two things. Now, sometimes when you're born, you can have a parent or two who have an inherited mutation, and you can inherit that. That's called a genetically related breast cancer, and Sumeda's going to talk more about that. In my world, they're very rare. 90% of the cancers are not that. There's 10% that are. Now, of those 10% that you inherit from a mom or a dad, that BRCA, the BRCA1, BRCA2, however you want to say it, breast cancer gene 1, breast cancer gene 2, that's a bad animal. They kill people. So although we think that breast cancer is, if you have a big family history, most people don't have a family history. But if you have a family history and you have one of those genes, well, that's a bad actor. And that causes me to do things differently because I want to make sure you live to be 85. And so it gets a bad rap. So that's that Angelina Jolie thing, right? She had a BRCA mutation. So ethnic background, we have a lot of information about white Caucasian females. And they're more likely to develop it than Black, Hispanic, Native American. However, it's been on the news this year, and rightfully so. If you are African American and you get breast cancer, it is very aggressive. Now, we got one clue from the last talk that I had never put together, right? We got that clue. The clue was that they have higher levels of this PFAS than we do, and disproportionately so. Is that why they're more aggressive? I don't know. But what I know is if an African American woman comes in my office, I treat her different. I make sure we dot all our I's and cross all our T's. She doesn't have a different algorithm today because we don't have enough data to get a different algorithm. Yeah, because they're not in the clinical trials. They're disproportionately not in the clinical trials. Having said that, most of them are estrogen receptor negative and more aggressive cancers. If you're Native American, you're least likely to have breast cancer. That doesn't mean that you can't have it. I have a lot of Native Americans in my practice because we have a lot in the area. Asians, women are more likely to develop breast cancer at a younger age, but the least likely to die. There's so much we don't know. That's all I'm going to say. There's so much we don't know. Is that environmental? Is that how they eat? Is that how their body is? We just don't know. There's too many things. Too many things.
I'm kind of surprised when the Native American women aren't higher because we changed their diet so drastically when we started messing with their, moving them around and taking them and putting their children in schools and all that stuff. We changed their diets drastically.
Mm-hmm. Well, it is interesting, right? And so the question is, inherently, is there something different about that? Right now, in our area, well, they have a wonderful health system and they're getting screened, right? They make sure they get screened. If they get screened, you find it earlier and that sort of thing. So the question, there's so much to it, right? There's so much to it. But yeah, I mean, so we do have data that Asian American, Japanese descent who came over to America, changed their diet, increased their risk of breast cancer when they came over and changed their diet. If they came over and didn't change their diet, it did not increase their risk, which is so weird. But yeah, so is diet, maybe it's one factor. Yeah.
I know their
It's too
diet
bad.
rate has increased greatly too over the years for the Native American people.
Yeah, it's so interesting. So more to come, more to come. There are unique things about your breast that you're born with that you can't change. If you have dense breast tissue, that's the one on the far left, okay? We're trying to find a white glob in a black background. But if your background's white, it's pretty hard to find your cancer, right? And so this is dense breast tissue. Dense breast tissue often is, your grapes have a thicker rind around them. If your breast is a set of grapes on a vine, your grapes have a thicker rind and it fills everything in that we can't see as well. And increased breast density and changes with fibrocystic disease increase your risk of breast cancer. But part of it is because we just can't find it. Breast changes can affect, if you have atypical ductal hyperplasia or atypical lobular hyperplasia, it increases your risk 6 times because you're on the first step of that pathway to get cancer. You made a mistake and your body didn't find it. Estrogen exposure. Well, this is so interesting just from the time that I've started practicing till now. So I've watched women come in, and when I first started, women's first period was maybe high school, right? I have some little ladies, their first period was 19, they got married at 21. Holy cow, right? But today, we have girls getting periods at 9, right? That's very common. 9 is young, I can't imagine. 9 is young. So what really matters is the time that you have your first period to the time that you have your first live birth, because you have unopposed estrogen cycles for that time. So imagine if you live out east You get your first period at maybe 12 now, but you don't have your first child till you're 40. That's very different than the little old lady I had that was 19 who had her first child at 21. Because when you get pregnant, we stop the estrogen cycles and you get a break. The number of kids you have. I come from a family of 8. My father's family had 15. She spent all that time without cycles, right? Today, you might have 1 or 2. I have 2 kids, right? You might have none. So you never get a break in those cycles. So that estrogen exposure that you have makes a difference in your risk of breast cancer. And on top of that, late menopause. We are having menopause later and later, sometimes due to chemicals. We talked about that we were giving people hormone replacement therapy. Sometimes just because we're having menopause later and later because we're getting heavier. And every fat cell makes a little bit of estrogen, and it just causes us to peak a little bit longer and keep ovulating. And so it's so interesting. We come from a generation that had birth control pills available. I mean, that's been in the 1960s. And so if you had low estrogen levels and you took birth control pills and you got supra high, it probably increases your risk. If you had normal estrogen levels or low and you took it and you got to normal, it probably doesn't increase your risk. Taking extra hormones if you weren't low to begin with might increase your risk. The problem is we don't have great blood tests. We don't have great saliva tests. We don't have great any tests to tell exactly what those hormone levels are. We do the best we can. There are some salivas, there are some blood tests where we try. The general community hasn't really accepted those, which is interesting. If you remove your ovaries before age 45, it actually helps you because you have less estrogen. The problem is you can get osteoporosis and you can have a problem. So there are pros and cons. Estrogen helps our hearts, it helps our bones, it helps our brain, it helps lots of things. If you breastfed your children, you don't get your periods back right away. So again, it helps. You have less estrogen exposure. A DES daughter increases your risk. That's one of those chemicals that we know increases your risk. And then that was a drug that was given to mothers to dry up their milk. The only problem is it caused an increased risk of breast cancer. We just didn't know. It's one of those things, where we think we're doing a good thing. Like we were talking earlier about California. I mean, those wildfires, of course everything should be, have some sort of flame resistant something. The problem is that they increase the risk of those chemicals, right? Like it was the best of intentions. The problem is it caused a problem. Same thing with the DES. It wasn't on purpose that they were trying to give people breast cancer. PCOS increases your risk of breast cancer. We don't ovulate in a regular pattern with polycystic ovarian syndrome, like your PFAS, that's my PCOS. Polycystic ovarian cancer can increase your risk of breast cancer. You can have irregular cycles and ovulate at irregular times and have an overall increase in your estrogen levels. So those are all things that can cause it. So what about, I'm sorry, I hit something. All right, what about radiation? Boy, this is a big one. And this is a good group to talk about radiation. Ionizing radiation is all over. We get it from our microwave. We get it from the sun. We get it from, it is all over. We get it from our cell phones, right? We get it from radiation from our mammograms. We get, the biggest one that we have actually studied, that we know really causes breast cancer and we've studied it well, is if you're exposed to ionizing radiation at certain periods of time in your life. We use it for non-Hodgkin's lymphoma. We give them chemo and radiation, and it really made a difference because that's a cancer that you get in your 20s, and those people are living to be 80. The problem is we had to give them the radiation to get them over the lymphoma, and then 20 years later, 30 years later, they might get a breast cancer. We used it ionizing radiation for acne for a while, and that's where we really saw it. We used ionizing radiation for thyroids, and that's where we really saw it. you know, if a good thing's working, why not do it on everything, was kind of the theory at the time. Best of intentions worked. The problem is we didn't understand the long-term sequelae. And so that is a risk factor that we have to keep in mind. They should be screened differently. They should be in a high-risk program, and because of the secondary cancers from the treatment they got. Oh, the hard one. All right, our body mass index makes a difference in our risk of breast cancer. And the problem is that it isn't just that every fat cell makes a little bit of estrogen. It's that the extra weight that we have on causes inflammation, causes mistakes, and those mistakes may not be picked up, and then we cause a cancer. It's really, we think the common denominator is going to end up being inflammation, but it can affect 7 cancers. It's not just breast anymore. It's 7 cancers. If we can stay in our normal weight class, we decrease our risk of getting cancer.
What is a normal weight? I always am curious. What guidelines?
Yeah, well, you're going to be scared by this because the research is based on the insurance charts. And I've always said, I have big bones though. They don't account for me. I don't really have big bones. I've done the bone density, but I'd like to say that. But it isn't. So my general rule is the way the insurance companies calculate it, because they are just actuaries and they don't look at people and they don't care. They're just trying to save money for their insurance people, right? And the best way to calculate that is to say, for every 5 feet, you get 100 pounds, okay? For every inch over, you get 5 to 10 pounds, and that's your range. So if I'm still 5 feet 2, I get 100 pounds for my first 5 feet. I get 5 pounds for each inch after, so that's 110 to 120 pounds. I don't weigh 110 to 120 pounds. I wish I did. That's the way you calculate it. And that's what they use for the studies to calculate this. And that's a scary thought. But that's really true, and it gets you in the right category. So what I can tell you is it's a little tricky. The BMI calculator that's on here will do it in a more, they take your height and weight and figure it out. And you can, I put the calculator on there and you can figure that out. But most Americans are overweight or obese today. Over 50% of Americans are overweight or obese, which is really, and we're only getting heavier. 17% of all breast cancers may be linked to an excess in weight. So if we just got people to lose weight, we might be able to spare 17% of breast cancers. That's a lot. That's 33,000 cases. Imagine how that would help our economy and our healthcare expenses and everything else. And that's just the money part. What about the actual personal part? If you've had breast cancer, what if you could prevent it just by keeping your weight down? Oh, another hard one in Wisconsin. Oh, I know. All the good stuff. I'm getting on all the good stuff. Alcohol increases your risk of breast cancer, and it's not just, it's not just breast, it's different cancers too. If you drink 1 drink a day, it increases your risk 10%. 2 drinks a day, 20%. 3 drinks a day, 30%. A drink is 4 to 5 ounces of wine. That's like a sip. That's like hardly a glass of wine, right? That's hardly a glass of wine. It's 1 beer.
It's a Wisconsin sip.
It's a Wisconsin sip. Yes, that's exactly right. I have one cute lady in my practice that likes her wine. She likes her red wine, and she liked her red wine every night. So she just parcels it out to 2 ounces every night, and they increase the price of the wine that they buy now, because now she can buy the good stuff because she's only drinking 2 ounces 4 days a week. And I laugh so hard, but her point is I'm not giving up that red wine. It is interesting. What I can tell you today, I mean, when this first data came out, I was hoping it wasn't true, but it really is true. It's been very durable for a long time. But today we have Oprah having a non-alcoholic wine that's not so bad. We have O'Doul. We have more than O'Doul's now. We have all kinds of non-alcoholic options out there. And so there are non-alcoholic options out there. This is really true, it's really important, and we really need to be thinking about it. So people ask me, well, what's the mechanism? Is it just weight gain? No, it's not just weight gain from alcohol. It has to do with how estrogen goes through the liver. We have good estrogen and bad estrogen in our body, and the good estrogen turns into the bad estrogen turns into the good estrogen in the liver, and the alcohol seems to mess with that process. That's my best, easy explanation. So it gets detoxified in the liver, and the alcohol seems to mess with that.
I thought grapes had a lot of antioxidants in them though.
There are, right? So how do we do this? We know that that in that wine, red wine, let's be specific, red wine has a lot of antioxidants, and we know that if you drink your red wine at night, you decrease your risk of heart disease, right? And so the problem is we got to weigh these risks, right? So yeah, I mean, we have to be smart consumers. You know, Wisconsin's amount of intake is probably a little too much, right? Just saying. But if you want to decrease your risk, and you know you're at high risk, or you have other risk factors that you can't control, you might want to think about cutting back. Lifestyle habits, another good one, but harder one for our area, I think, because we have such seasonality. But we can get creative on this. What we know is there is an exercise prescription today with data to tell us if we move, we decrease our risk of breast cancer. And our body doesn't care if we go to the, we put on our cute workout clothes and go to the Y and do an exercise class. It doesn't care. It's calculating from the minute we wake up. It can be steps. It doesn't care how hard it is. Yes, if you do more vigorous activity, you can decrease the number of minutes, but it doesn't really care, and it keeps track. So if you park your car at the far end of the parking lot to drive in, it knows. It knows if you take the steps or you don't take the steps. It knows. What we do know is if you can have regular exercise and you can regularly move, and it doesn't really care how you move, you just move, you decrease your risk of breast cancer, which is really interesting. A lot of research going into this right now. We've also been able to show if you do this and you have breast cancer, you decrease your risk of getting the cancer back. The body doing what the body is designed to do, it does better. It's really interesting. So prevention is so much more. We got to weigh the things we can control and the things we can't control. But not all risk factors are the same. There's some nuance to this. So if you have a 1,500-pound thing coming on top of you and somebody says, hey, you know what, you might want to look up, well, you're probably going to get smashed. But if somebody's screaming at you, move, or pulls you out of the way, you're probably going to do better. That nuance is so important because we are constantly being bombarded that coffee's good or coffee's bad, that eggs are good or eggs are bad, that, oh gosh, she did scare me with that talk last time because there's so much. Like, we're exposed all the time. The problem is, like, our body does pretty good. Our body really does pretty good. We're all sitting here and we're listening to a talk. So we just got to give it that extra advantage to do even better. But here's a list of many of the things I talked about and where they sit on the risk scale. So if you have an elevated BMI like I do, my relative risk is 1.2. But if I had the BRCA mutation, my relative risk is 200. That's like off the scale, right? Childbirth over age 30. I had my first child over age 30. I was in the middle of training, right? It increased the risk to 1.8, but that's not like having a BRCA mutation. And so we are bombarded all day long about the things that increase our risk, you know, and how we need to drink water this way and not that way, and we have to get rid of chemicals this way and not that way, and the environment plays a difference, but they're not all the same. And so part of being a good consumer of information is understanding where they fit on the risk scale. So, prevention is as easy as 1, 2, 3, 1. Nail down your family history because it does make a difference. You saw that BRCA mutation is 200. All right? Know your risk. How many risk factors do you have? And then make a plan. How can you calculate your risk? The evidence-based models that we have available today are right here, the two that are most popular, the Gale and the Tyrer-Cuzick. And you can go on, they're going to ask you when you had your first period, when you had your first live birth, how many kids did you have, how many breast biopsies do you have, how many relatives with breast cancer, and they're going to calculate a risk for you. So know your risk. Normal risk is somewhere between 1 and 14%. Moderate risk is 15 to 19. Anything over 20%, and you're high risk, and you should be followed differently, and probably have different screening and different modality if you're high risk. If you're high risk and you have a risk greater than 20%, we're going to recommend a breast MRI. The breast MRI, this is a normal mammogram, and you can see the MRI found that cancer. It can find a cancer 3 millimeters or greater. That's a half a piece of rice. It can find a cancer 98% of the time, where a mammogram is about 80. It can find a cancer 2 years before a mammogram. So if you're high risk, it has some great benefits. It has some downsides. It's more invasive. We have to give you an IV and some IV contrast. People don't like the contrast. The contrast is gadolinium. The best way to deal with the contrast is drink a lot of fluid before and a lot of fluid after so you can get it out of your system, but there are concerns about the contrast. There are concerns about the false positivity. It's so sensitive that it can give us false positives. And we may have to work them up with an ultrasound or an ultrasound biopsy. But a breast MRI is the gold standard today, and for people who are high risk, we recommend it.
Does insurance cover that?
If you're high risk, which is why you need to know your risk. Yeah. Prevention medications, we now have medications to decrease your risk of breast cancer. They can pretty much decrease your risk of breast cancer by about 50%. There are two different categories. One are selective estrogen receptor modulators, and the other ones are aromatase inhibitors. Selective estrogen receptor modulators, I call them, it's kind of like if you have a keyhole, you put tape over the keyhole. It kind of puts tape over the estrogen receptor so estrogen can't get in. Aromatase inhibitors, they're a ring breaker. So estrogen is a molecule that's aromatic. It forms a little stop sign shape. And the aromatase inhibitor stops it from forming the stop sign shape, so it can't fit into the receptor. And so these are two drugs we can use today. They both have side effects, but they both are good at decreasing your risk. If you're very high risk and you want to decrease your risk, we have drugs available now. We can reduce our estrogen exposure, sort of. We can't reduce what's internal. We can't start a period. We can't stop a period. But we can affect some other things like oral contraceptives or hormone replacement therapy. We can affect it by breastfeeding. Breastfeeding is a good thing if you can do it. I never like to shame women who can't do it, but if you can do it, it's a good thing. It does decrease your the time that you restart your periods, but the breast does not mature with all of its defenses until after the birth of our first child and until after the milk comes in. Nature's an amazing thing. So we have the best defenses if you can breastfeed. But if you're just pregnant and your milk comes in, that counts. Oh, other modifiers. There are dietary choices that we can make to decrease our risk. Most of them are pretty obvious. Natural food is good for our body. Chemicals aren't. And that's basically what this says. So a colorful plate is a good thing. A variety of fruits and vegetables. 5 to 8 fruits or vegetables a day decreases your risk of all cancers. And that's about 2.5 cups. So a half a banana is 1, a half an apple is 1. But 2.5 cups a day, you get all the micronutrients. You get all the beautiful things that nature has arranged for us that help us if you eat those whole foods. I use an apple as an example. An apple is really high in carbohydrates. But nature's amazing. It made it with a bunch of fiber so that when we eat a whole apple, it goes through our system really slow and we don't get the big spikes in insulin. because nature's amazing. We have other fruits and vegetables that have micronutrients like zinc and all sorts of magnesium and all sorts of things that really help our system work the way it's supposed to work, that we just don't get in the same way and we don't absorb in the same way unless we eat them naturally. So a good diet makes a difference. Limiting processed food makes a difference. So lifestyle modifications: maintain your BMI, limit alcohol, stay active. All are things that you can control and decrease your risk. What about surgical prevention of with using or taking out the ovaries? Right? If estrogen's bad and you're high risk, what about taking out the ovaries? We really reserve that to women who have a BRCA mutation if we're way up high at that 200. It's rare that we do it otherwise unless they need that procedure. And it's rare that we do it before age 40 or 45 because we don't want to cause osteoporosis. What about surgical prevention? We reserve this for women who have the mutation, a genetic mutation that causes the risk. We usually don't do this otherwise. There are a few instances where we might, but it's unusual. And so this is a picture of a woman without a mastectomy and a picture of a woman with mastectomy. And it's just to prove the point that we've come a long way in our reconstruction. We can take a breast off and leave the nipples. We can use implants. We can use your own tissue to make a breast. We can do all sorts of things. So we've come a long way in what we're doing to when we do breast surgical prevention. So managing your risk makes a difference. These things that we can control, right? Staying healthy, moving, decreasing your alcohol. They calculated that they think that we can prevent 38% of cancers by just living a good life and doing what we're supposed to do. That's pretty good. That's pretty good. So what can we learn from the cardiovascular model? So we kind of all grew up where heart disease became popular. We all heard about it. We all heard that we're supposed to monitor certain things like our blood pressure, our cholesterol level, our lifestyle habits. I think I first heard about alcohol and disease with heart disease, right? A couple glasses of wine is good for your heart. And we're supposed to move because the American Heart Association told us that. And watch what we eat because the American Heart Association told us that. I think that model works very well. They had prevention medications to decrease our blood pressure. They had prevention medications to decrease our cholesterol. And most of us in this room, if a doctor told you, hey, you might need these medicines or you might get heart disease, we at least think about it. Usually we think about it, then we try to go exercise, lose weight, and then we come back, but we think about it. And so this works well. And we had widespread adoption, and we were able to show a difference. Well, we can do the same thing using our 1, 2, 3 plan. You know, if we nail down our family history, we can figure out if we have a genetic mutation, and we can figure out a risk, and then we can intervene. We can tailor your imaging if you're high risk, just like they give you blood pressure medicine. We can intervene with medication if we needed to, and we can monitor and work on our lifestyle changes. So the same things that we do for heart disease really apply to breast cancer as well. So are there any advances in early detection? So I actually picked this because I wanted to look at the data, and I just haven't had time. And so I picked, so this is a pet project for me, that I included this in the talk today, because I wanted to know. Well, number one, there is promise in early detection of cancer when we talk about how the story of the BRCA mutation, or that genetically related breast cancer. So I was in high school, and somebody who worked on the DNA project came to my high school and gave a talk because he was part of the research team about how we were finding out the genetic makeup of a human body, so the DNA of a human body, and what that was, so the human genome map. And I was like, well, that's kind of interesting, but kind of boring, but okay. Right? I mean, like, I took note because the whole school went to hear him talk, and he happened to graduate from the school, but I didn't understand what it meant. So knowing what normal is, then what happened next is researchers from the National Cancer Institute took a look at a bunch of breast cancer patients who had breast cancer, and they compared them to normal to see what was wrong. And there was such promise that we're going to find out the cause of breast cancer. And we found out the cause of 10% of breast cancers. We didn't find that, 90% were too weird that we don't know. But there were 10%, so they were able to take normal, compare it, and say, you know what? There is this group of patients that have the BRCA mutation on chromosome 17. And then they went back to see what those women looked like. And what we found out is they were diagnosed with breast cancer at an early age. They usually had aggressive breast cancer. 50% of their relatives had breast cancer. They were passing it on at about a 50% rate. And so we were able to characterize them. Then we were able to go ahead and say, you know what? We're going to screen them differently and treat them differently because you know what? They have a bad cancer. And now today, because we know where that gene mutation is, we can tell, and we have ways that we can treat them differently by exploiting that mutation. And so we've come full circle. And so the promise of the BRCA story is that by detecting these genetic mutations, we may have some idea about how to treat these people. And that's a big deal. Early detection saves lives. So the 5-year survival of a patient with stage 1 breast cancer is 95 to 98%. That's pretty good. Stage 2 is about 80%. But if you have stage 4 disease, only 26% live 5 years. So we need to catch women early because it saves lives. Screening mammograms decrease the chance that you're going to die of breast cancer by about 40%. Mammograms don't find all cancers, though. That is what we have. I've spent the whole month talking about get your mammogram because it's Breast Cancer Awareness Month, and I believe in it. But gosh, we know we're missing some. We know people with dense breasts, we're missing those. Not everybody's going on to get an MRI. So not all countries have access either to mammograms. So there needs to be a safe, effective way that we can screen people and find them early so we don't have the devastation caused by late-stage breast cancer. So what about a blood test? So are we there yet? We just finished up a clinical trial at St. Vincent's where we took blood from women with breast cancer and we're comparing it to normal to see can we have a blood test. But we're also doing that as a validation study for one of these blood tests that they don't tell us which one it is, but I have an idea that I'm going to show you in a second. But the cancers leave behind some biomarkers. So if there's a cancer in you, it leaves behind little breadcrumbs so that we can follow the path, right? And those breadcrumbs, our body says, hey, you're not normal, so I'm going to make an antibody against you because I don't know what you are. All right? So we make an antibody against the breadcrumbs, and then each cancer has a different breadcrumb, say, and it has a different reaction to that breadcrumb, a different antibody. And then the big difference today is we can use artificial intelligence to find those patterns. We never could figure that out, but there are just too many patterns, too many things. But artificial intelligence can then use machine learning to learn those patterns of those breadcrumbs from each cancer, okay? Are you following me, sort of? I see some starry eyes, but I'm trying. All right, the advantage is it's easy, right? How many women in here would rather have a blood test than get a mammogram? Right, yeah. One test can find 50 cancers. It's not just breast. That's an advantage. We have breast cancer, cervical cancer, colon cancer that we're screening for now, lung if you were a previous smoker. And it may increase the adherence to screening because some people don't want the radiation from mammograms, right? It allows screening in other countries. Those are big advantages. The disadvantage, when we ever roll out this test and people start getting it, we do not have the infrastructure to deal with all those cancers. We just do not. There's no evidence that if we found it early, we're going to decrease deaths, but we think there is, just based on that data I showed you about early stage, okay? There's no evidence we'll decrease cancer-related expenses because these tests won't be free, okay? So what are the blood tests we have out there right now? The first one is my hint that that's what we studied, because it's up for FDA approval in next year, 2023. And that blood test uses cell-free DNA methylation. It adds a little group of atoms to the DNA, and it creates a pattern for each cancer. Don't know.
There you go.
All right. And it costs about $1,000. I think that's high, have to be honest. Maybe it's accessible, maybe it's not accessible. But it's ongoing in clinical trial, and the FDA is supposed to approve it in 2023. The House and Senate have entertained, not passed, your vote counts. They've entertained consideration that Medicare would pay for this test. That would be a big deal. Because if Medicare pays for the test, the other insurers follow. Again, we do not have the infrastructure in place to deal with that, but very interesting, very interesting. Maybe we just start with high-risk people. Maybe knowing your risk is a big deal, right? The other one is CancerSeek, and that is, they actually looked at preset DNA mutations, so not fragments, not autoantibodies or breadcrumbs, just pre-specified DNA mutations to try to figure that out. Still under clinical trial, not ready for prime time. Last one, use fragmentomes, which is how I came up with breadcrumbs, because I'm like, that is a weird word. But a bunch of fragments of DNA forming little masses, breadcrumbs, and that's ongoing clinical trial, but not ready for prime time either. Whoever comes out with this first really is going to make a lot of money. So that's the blood test. I think it's interesting. I think it's exciting. I think it would be an advance. I don't know if we're ready for it, but you know, we've done bigger things where we had to change quickly, so we can do hard things. Innovations in breast imaging. We do have some things coming down the pike. I mean, we really have some things coming down the pike because we have had mammography since the 80s. It's now 2022, and that's still our primary modality. It's safe, it's effective, it's cheap, it's just archaic in some regards. So we have abbreviated breast MRI. If people don't want to do a full MRI, 1,000 images, a lot of gadolinium, there is an abbreviated MRI, but it's the same gadolinium dose. It's just 50 images, goes faster. We might be able to figure it out. Usually the cost is about $500 instead of $4,500 or $5,500. So the cost is better. It might be more accessible to women who are high risk. As we determine that you're high risk, we're going to need a way to test them. We are doing PET scans, but instead of using what we normally use for the PET scan, we're using a marker that can help detect breast cancers. It requires uptake. You still are injected with technetium-99. Technetium-99 is a radioactive substance. It's a microdose, but it's still a radioactive substance. So pictures are similar to a PET scan. It has some promise. I think it has some promise. You don't have regular radiation. You have radioactive radiation, but it's not the regular ionizing radiation. The F-18 PET scan actually takes a radioactive fluoride and combines it with estrogen to show us increased areas of estrogen take-up, which is kind of interesting. And it's been, it's a molecular marker, and we're finding some good evidence. Again, not for screening though. Right now it's still only diagnostic. And then contrast-enhanced mammogram is really finding its own way. It's not an MRI, but the sensitivity and specificity are close to an MRI, but they still give you an injection. It's just omnipaque, which is what we use for CT scans. And so it's not gadolinium. The gadolinium, there's some concern about long-term effects with gadolinium. So if you were high risk and you were getting MRIs over a long period of time, maybe this is an opportunity so you don't have to get as many MRIs. What they do is they inject you with Omnipeg and they take a mammogram. We're still back to the mammogram, though. I don't know if anybody noticed. We're back to the mammogram, but it shows us areas where there's increased vascularity. So cancers make new vessels, and then we can see this new vascularity and find cancers. So there are some innovations in screening. Elastography is coming along. This is an ultrasound technique where we do an ultrasound, but then there's sort of a pressure bag placed over the top of the breast. And the pressure bag will squeeze normal fatty tissue, but cancers don't squeeze well because they're hard like a pebble. And so then it measures how squeezable it is. It's kind of like the Charmin thing. It measures how squeezable the breast is. And the red is where it did not compress, and the blue is where it did compress. And so this does not have radiation. This does not have any chemicals. But elastography is coming along. And so it's got a place. I think it's coming along. So to wrap up, all right, first of all, every cancer is formed from a problem with the DNA, but it is so complex. I do think artificial intelligence patterns and different things are going to make some breakthroughs in breast cancer, even on the DNA level. I mean, I think it's coming along. Breast cancer prevention is more than a mammogram. You heard that. It's about lifestyle changes. It's about possibly medications. But most importantly, know your family history, know your risk, and then figure out a plan. That's really what you need to do. Very much like cardiovascular disease. Lifestyle modifications make a difference. Living a good life makes a difference. Watching your weight, limiting alcohol, keep moving, makes a difference. DNA is a promise of the future. The BRCA story proves it, and we're going to hear more about genetically related breast cancers in your next talk after lunch. I'm priming her up. The multi-gene blood test, I think I keep an eye open for that because I think that's kind of exciting and may change the whole landscape for us. And then lastly, lots of imaging innovations may prove valuable. We're working on it. I know there's got to be something better than what we've had since the 1980s. All right, so any questions for me? Yeah.
You just talked about the blood work. Is that going to create all kinds of new jobs for people having to learn to read these things, or is that not going to really affect that industry too much?
Oh, I think in the same way that COVID required a lab infrastructure that we did not have, it will require a lab infrastructure we don't have. But then once they find that you have it, if it's only microscopic, it's going to be an influx of imaging to find out where it is and how big is it and what do you have. And then we're going to have a whole infrastructure of algorithms. When do we start treatment or when do we don't? Or can we affect it without treatment? Or which ones matter and which ones don't? Yeah.
So are you talking in the nursing program here about this? Or?
No. I think it's really interesting. The question is, I wanted to look it up because I've heard, my phone tells me grumblings, right? My phone hears me all day long, so it's sending me Google stories, right? And so I saw this blood test for cancers, and I've been meaning to look it up. I was surprised that it's due for FDA approval in 2023. I was surprised. I'm like, what? But I can't imagine, no, that was a biased statement. Our government moves a little bit slower than that. That I think that it won't, Medicare and Medicaid, even if they approve it, it'll be down the road because we have to have so many other things in place first. Yeah. So it's interesting. So yes, I think there's a lot to it. I think it's going to be a big deal. I think it'll change how we treat cancer.
So are there any other countries that are doing that right now?
Don't know. Didn't see it. Oh, Australia was in the research I looked up, and England. They don't have the infrastructure either. People are worried about that. Yeah. Yes.
3 questions all about the advancement in identification and treatment. So you just mentioned, so we identify early, when do we treat and when do we not? So are we researching at what stage? Is it so early stage that lifestyle modification and natural aromatase inhibitors and herbal support of liver detoxification, all these kind of things can help reverse the early stages,
Mhm.
okay? Second, is there, when you were looking at the screening, any more research on thermograms effectiveness in terms of early stages, and then that oncoblot blood test?
Well, the oncoblot is one of these.
It is.
Yeah, it's like that. It's a little bit like that, I think. The oncoblot that I think I know is a little bit like that. Okay, let's start with question one. Yes, but not to the extent that you'd like. We are investigating when to treat and when not to treat. Part of the reason we stopped doing PSAs on everyone is just that. There are many men who have prostate cancer that it never turns out to be anything. So in breast cancer world, there are some ductal carcinoma in situs that never go on to do anything. And so we're just finishing up a clinical trial currently where women with ductal carcinoma in situ, which is stage 0 breast cancer, can opt for observation or normal treatment. And we're following them over time because maybe we're over-treating some of them. They have to be early stage. They have to be grade 1 or grade 2 early stage, nothing bad about them. No other history of cancer, like the best of the best. But we currently have a clinical trial, and then we'll follow them to see, have we been over-treating these women? So yes to that, but not in the way that you said it.
No.
Are we testing interventions to see if it makes a difference? No. First, we're testing to see if we're over-treating. But that would be a great study. Other countries are trying. Other countries are trying more than we are. The second question was about